Thanks again for joining us at the Vascular Surgery podcast today for our viewers and our listeners. Today we'll be focusing on our Heart and Vascular Institute affiliate program. And I have two of my colleagues joining me, Suma Thomas, MD. She's the Vice Chair of Strategic Operations for Heart and Vascular Institute. And again, Chris Smolak, MD. Chris Smolak is one of my vascular surgery partners, and he's the Chief Quality Officer within the Vascular Surgery Division. So, I'd like to start this off and kick this off with an idea that I heard from Dr. Mihalovic last week. We were having one of our State of the Clinic talks, and Dr. Mihalovic said, what is the legacy of us as individual care providers, and what is the legacy of our facility, our enterprise, the Cleveland Clinic? And it's really going to be determined by how many people we can touch. And we treat patients individually, but as much as we can extend our breadth of care throughout the region and throughout the United States, that'll impact patients more significantly. And so I think it's timely that we discuss the affiliate program. I'll begin with Dr. Thomas. So Dr. Thomas, maybe you can give us the history of the affiliate program. I know you've been involved for some time.
Yeah, the affiliate program started about 15 years ago, and it did start with Dr. Cosgrove and Dr. Svensson, who started the affiliate program by looking at a hospital in Rochester. Rochester Regional is what it's called right now, and this is the first program who asked Cleveland Clinic, you guys do things really well, your quality is great, can you help us? And so they started the consultation 15 years ago, and then the program decided to become an affiliate of the Cleveland Clinic. And since then, the team has grown, and we've done many more consultations and affiliations across the country.
So that's interesting, this idea, the history of this evolution of this service line and this offering that we have. How do you distinguish the consultation from the affiliate? We hear all the time about the affiliate programs. How do you distinguish those two?
Yeah, we're really lucky to have a very diverse team of individuals that work on our team, and we do consultations across the country. And what we do in these consultations, the core is really quality. The most important thing that we think at the clinic and Heart and Vascular Institute and the entire enterprise is our quality. It's incredibly important, it's core to us, and it's core to our mission. And so what we do is we evaluate programs, and we evaluate programs on their quality, and we evaluate programs on their leadership and their operations. And what we do is we do this initial evaluation across the service line, cardiac surgery, cardiovascular medicine, and all the subspecialties. And then we provide recommendations and findings to the hospital, and that's the consultation phase. So after the consultation phase, both sides, both hospitals, the Cleveland Clinic as well as the hospital that's consulting with us, they decide if they're interested in affiliation and having a further relationship with the clinic.
So it sounds a lot like healthcare dating, if you will. So
we call it that sometimes.
So one of the things I've heard Dr. Svensson describe is that, we can't promise a hospital that will improve their volume, but what we can promise them is that we'll improve their quality, because here at the Cleveland Clinic we pride ourselves on measuring and improving outcomes over time. Do you think that's fair to say? Absolutely,
and we're so lucky in cardiac surgery and cardiovascular medicine and vascular surgery to have ways to measure quality. In cardiovascular surgery, cardiovascular medicine, and vascular surgery, there are registries where we can actually talk about what is the actual measure of quality for a specific procedure or surgery. And so we have the STS database and the ACC NCDR database to turn to. So physicians and hospitals can turn to these databases and look and see how Cleveland Clinic compares to other hospitals across the country and how their hospitals compare to us and other hospitals. So it's a great way to be able to measure quality. And because of that, we actually use those core pieces when we're doing these evaluations with hospitals across the country. We're able to turn to that to make sure that we have metrics to look at, but also metrics for our goals. You know, how do we improve a certain metric? How do we make sure that, for example, our prolonged ventilation is better? How do we work on that? And so it's a wonderful thing to have metrics to work towards improving. So the consultation phase and the affiliation phase, we can work towards those quality goals.
Dr. Smolak, so as Chief Quality Officer, I know that we participate in the Vascular Quality Initiative, so maybe you can describe that, our participation in that module.
Yeah, so similar to the STS and other databases, the Vascular Quality Initiative is actually a patient safety organization that was started in conjunction with our national society, the Society for Vascular Surgery. And that was formed in New England some years ago, over a decade ago, and has been extended nationally. And similarly, looking at various quality metrics of all the procedures that vascular surgeons do. So there are actually 12 modules. We participate in some of those that we are more heavily involved with in clinical care, particularly the aortic modules and the carotid modules. And as that extends, not just in vascular surgery, but any practitioner in the hospital who's also doing those procedures. So we have other members of cardiology and cardiac surgery also doing related procedures to us. All of those done in a particular hospital or health system are gathered. We can measure against our own region, which is the Great Lakes region. We can also measure against national standards as well.
Yeah. So again, there's a heavy emphasis on outcomes and quality, and we can't improve if we don't know where we're starting out and what our goal is, to Dr. Thomas's point. So maybe you can describe the participation in the carotid and the aortic. What are some high points of those outcomes?
So one of the outcomes that we look at with carotid is not just within the VQI, but we also participate in a JACO stroke center of the hospital, and that's with cardiology, as well as with our Neuro Institute. So there are some benchmarks to be certified as a stroke center, and that is in any asymptomatic carotid intervention. So a person who comes for a carotid intervention but has not had symptoms, the stroke rate from that procedure needs to be less than 2.5%. Similarly, any person who is having symptoms from a carotid disease and needs a carotid procedure, the post-procedural events should be about 5% or less. So we are happy to report we are well below those in the 1% range for each. So that's one example in the carotid area where we need to maintain great outcomes so we can offer great care for our patients.
So what do you attribute that to? Again, I think many practitioners kind of look at the surgeon perhaps and the procedure, but for all of this cardiovascular care, it really is a team of teams concept. And so when you look at carotid surgery, what are some of the important perioperative aspects?
So as you alluded to, it's not just one proceduralist or one surgeon, not even one specialty as it goes across a few, but this whole team approach. And I think that the appropriateness of care, which will probably be the next step that will be scrutinized in quality, indications for surgery and adhering to certain indications for surgery or for interventions, and using the best evidence to do that are the things that lend to that quality of care. Certain techniques that have been studied and shown to be most appropriate. And then, of course, best medical therapy, whether that's with or without an intervention or surgery, certain medications, all those guidelines adhered to, I think, leads to those outcomes.
And consistently applying those with the use of electronic medical records and the various modalities.
Yes.
So, Dr. Thomas, maybe you can give us an idea of the current affiliate arrangements and relationships throughout the nation. Are those geographically located, or?
Yeah, we have hospitals across the country. We have hospitals on the East Coast, the West Coast, and the Midwest. We have hospitals of all sizes. We have small hospitals as well as large hospitals that we work with. So it's the great thing is that the value proposition is really that you're going to improve your quality, and then also the return on their investment is really thinking about continuous improvement. How do you continually improve, for example, your access, how patients can get to the hospital, how you can be efficient within the hospital. So we really are emphasizing the importance of efficiencies, and we think that this is all very consistent with the message that all hospitals are sort of facing, is how do you become high quality with really good efficiencies, but also at a competitive price. So really we feel like this value proposition is really looking at all of those things, so that the hospitals can really compete in the current marketplace. And so those are the things we look at.
So it sounds like you've seen large market players, you worked with large market players that improved their quality. Mm-hmm. You've also looked at smaller organizations
Absolutely.
and enterprises that have also been able to improve their quality. And this is really utilizing a best practice approach. And at this point, 15 years in, I guess you guys have kind of figured out what the special sauce is in terms of evaluating a program.
Yeah, I think the most important part is really getting leaders on board and really having a standardization of care and trying to figure out like what are the best practices and how do we get everybody on board to make sure that everyone's aligned with the same goals. And so that's something that we are really proud of, is helping the hospitals to work, sometimes we work with independent physicians and employed physicians, and it's really great to see how they've worked together to help the hospital improve their quality. So that's something that we really learn over time. And one of the other great things is we always learn from every hospital that we visit. It's a wonderful thing, because as you guys know, the Cleveland Clinic mantra is we can always learn more, and so we're always trying to improve our own quality. So that's been a really amazing part of being part of this team, is always bringing back more knowledge for the clinic.
One of the things I've been impressed with is when we look at this triad of research, education, and clinical experience, I've seen some of the affiliates begin to get involved in some of the satellite, cardiovascular programs and really educating, and that's a critical part of this culture.
Absolutely.
Is educating one another.
Yeah. We do have some, joint CMEs across the country from time to time, and those really have been well participated. There's been great participation, and it's a way so that Cleveland Clinic brings innovation out to other parts of the country, but we really partner on those efforts, and really enjoyed that. Have you participated in any of those?
Yes, absolutely. And I think it's well received, and I think it brings the affiliate program into the culture, because this really is creating a culture that we feel is strong here, creating that culture within other organizations.
The other piece is that the affiliates are also exposed to the Cleveland Clinic through these wonderful tall rounds that we have, and they have access to tall rounds. And I don't know if do you want to describe the tall rounds as this wonderful forum where we have multidisciplinary lectures for our own clinicians, and then we actually broadcast those, and so it's a wonderful way for physicians and other practitioners to learn from a group of physicians from multi-specialty, multidisciplinary way.
That's right. That's fantastic. So, Dr. Smolak, we recently had a paper accepted to JVS Journal of Vascular Surgery looking at our open operative experience for our trainees. Maybe you can speak to this idea of volume, because we know that volume assessed critically and it helps to improve quality over time if one goes about that in a very thoughtful manner. And so I think our aortic outcomes are a function of that.
One of the interesting things that we found with our open aortic volume, and then again compared to the region and to nationally, is that we end up doing about 10% of the nation's open aortic cases, which is quite a good percentage for the participating hospitals in the 100s, almost up to 500 range of hospitals that participate in the VQI. And what we found was that we actually have a 0% in-hospital mortality for those. And those are open abdominal aortic aneurysms, which is actually, as you can tell by those numbers, is somewhat of a rarity in most places, but still needs to be done. And We also found that a lot of those patients, in involving our cardiology colleagues, we found that they have our institution had a little bit of a higher rate of troponins in the blood, which could be a marker for a perioperative MI. Not necessarily, but could be, where we see that's a lower rate in the nation in those cases. And what we think that is we are early recognizing some potential cardiac issues in those patients and dealing with them. And that piece of that quality comes from a lot from our interdisciplinary function within our HVI, our standardization of ICU care, and that part of volume, not just the amount of cases that you do, but the amount of just types of cardiovascular disease that you see across all your specialties within your ICUs extends to the care, and I think it increases that quality.
It's the sometimes the rescue that's just as important as the initial intervention, and I think we do a pretty good job of identifying a challenging postoperative situation and understanding through our experience how to manage that. Sometimes it's best medical management, and sometimes that requires an additional intervention, whether that's a cardiac percutaneous intervention per se.
The early, as you mentioned, the identification and the early identification also comes from volume and having seen that sort of play out over and again.
Yeah, that's a very, very good point. And so, Dr. Thomas, what would you describe as maybe an example of an institution that you've come into? And I know maybe looking at STS, they're a one-star institution, and you guys have had some success. Do you have some examples that you might share, maybe not by name, but as just by...
Yeah, we definitely have worked with various institutions, some who are at the top of their game, and they're really looking to just get to a slightly different level and to partner with the clinic on some different initiatives. And then we do work with programs who've struggled and have had some issues with quality, potentially some with leadership and putting the right leaders in place and the right physicians in place. So we definitely have seen some great successes and great, really, organization building the infrastructure that they need to be able to provide the quality and really provide the right leadership. So yeah, we definitely have seen a variety of institutions who have benefited greatly from the guidance that we've provided, but it does vary. It varies from institutions that are really struggling to institutions that are at the top of their game and are looking to get to even a higher level.
Sure. You know, it's funny. I've done some of the consultative work with the affiliate group as HVI has gone in to evaluate a program, and I think one of the things that's underscored after we evaluate and provide this extensive overview of vascular surgery is how many moving parts of that. You know, the vascular laboratory, which if you have a poor vascular lab, then your ability to identify, to post-operatively, post-procedurally follow patients, or even just to surveil patients over time is marginalized. So, you know, again, what would you say in terms of what are the other pieces of quality? When you look at quality, you know, hospital-associated quality, it's not just the procedure that you're looking at a number of different other metrics in hospital that have the opportunity to improve the outcomes of these patients.
Yeah, it starts when a patient comes to either clinic or to the operating room, having a service line of nursing care, of patient representatives at the front desk who understand those patients and their needs, and that sets forth the path, whether that patient's coming into the hospital for the operation and then they go to a cardiac or cardiology or vascular surgery specific post-care unit.
Yeah.
Same thing in the clinic. Those are all specialty nursing who are sort of used to dealing with those patients, similar to the vascular lab. The X-ray technicians in our operating rooms are specific cardiovascular X-ray technicians that are employed within our department and only do those sorts of cases. So I think those are the kind of things perhaps that you're referring to. Again, the specificity, understanding the patient's disease and the treatments that kind of all go into those good outcomes.
Absolutely. No, those are great points. So, Dr. Thomas, for anyone viewing or listening to this podcast that wanted to contact you to initiate a discussion regarding, just a preliminary discussion regarding the affiliate program, how would they reach you?
We can provide our email contacts. So it's thomas.s14@ccf.org. So we're happy to entertain any questions or and talk to you further about our program. We really enjoy doing the work across the country, and we welcome any inquiries about it.
Super. And Dr. Smolak, as you continue with your quality work within the department, what's one of your big ticket items for this upcoming year in terms of process improvement? I know you've worked on the EMR and standardizing some of our reporting methods so that we can extract data more readily.
Yeah, we've actually partnered with one of the companies that the VQI is using for their data extraction, so that we can. We're not there yet, but we're hopefully, rather than manually abstract this, it will be auto abstracted and smart pathed, so to speak, from the electronic medical record right into our own databases as well as into the VQI. But we also have a variety of quality improvement projects every year for our trainees. What I would like to see those sort of culminate into some continued improvement of our pathways. So
Yep.
when a patient again comes in, we sort of have that set standard pathway. I think we've worked toward that very nicely over the years. Certainly still some more work to go, but good care pathways for all of our disease processing.
I think the challenge that any vascular surgery department faces is that there are multiple procedures, types of procedures and disease categories. It's not a valvular disease, structural disease, and occlusive disease, and electrical disorders, but it's 20 different disorders that are treated surgically and procedurally across a broad spectrum. And I think that's one of the benefits of an affiliate or a consultative overview of what actually is going on within that department, and that oftentimes opens up some opportunities for what is not being done within that department, because there's a spectrum of procedures that are done for vascular surgery.
Sure. Yes.
All right. So thanks very much for all of you who are listening or viewing our podcast. This wraps up another session of our vascular surgery podcast, today specifically on the affiliate program at the Cleveland Clinic. Thank you again.